Though congenital left ventricle to right atrium connections have been described as early as 1838 at autopsy, the description by Frank Gerbode and colleagues was in 1958 in their surgical series. They described three varieties of communications. One, fusion of the septal leaflet of the tricuspid valve to the edges of the ventricular septal defect associated with the perforation of the leaflet. Shunt occurs from left ventricle directly into right atrium. 2. A defect or cleft of tricuspid valve close to its point of attachment directly overlying the VSD. 3. A combination of these two lesions. They also described the finding of bradycardia and rise in systemic blood pressure while closing the defect manually at surgery. This, they mentioned, was similar to the Branham reflex in case of a peripheral arteriovenous fistula. The rise in blood pressure due to increase in systemic blood flow stimulates carotid sinus receptors and causes reflex vagally mediated bradycardia. Though the initial descriptions were of congenital defects, later the terminology has been expanded to include acquired LVRA shunts as well. Possible reasons are invasive cardiac procedures, endocarditis, trauma, and myocardial infarction. Advanced cardiac imaging techniques like computer tomography, magnetic resonance imaging, and real-time 3D echocardiography have been useful in definitive diagnosis and anatomic characterization of the shunt. In the initial descriptions, oxygen step-up on cardiac catheterization at the right atrial level was noted and sometimes even mistaken for atrial septal defect. Different types of classifications have been in use for Gerbode VSD. Classification by Moss, AJ et al. Was into two types, direct and indirect. Direct defect involves the membranous septum from LV to RA, while indirect defect involves a VSD with accompanying tricuspid regurgitation. The echocardiogram shown here would come under the indirect category with VSD and TR through septal tricuspid leaflet fenestration. Sakakibara S. et al. Had classified LVRA communications into three types. Type 1 was a direct communication from LV to RA across the atrioventricular part of the membranous septum. In type 2, defect develops in the interventricular part of the membranous septum and just opposite in the septal leaflet of the tricuspid valve. These two openings adhere to each other and communication from LV to RA is thus possible. Type 3 is a combination of a large membranous septal defect with fissure and thickened and shortened septal tricuspid leaflet. In a more recent publication, type 1 is considered as direct and acquired with direct shunt through the atrioventricular part of the membranous septum, while type 2 is indirect and congenital with indirect LVRA shunt through a perimembranous VSD and a defect in the septal tricuspid leaflet. A case report describes a closure of Gerbode type 2 defect post-transcatheter aortic valve replacement with ambulatory muscular VSD occluder. First set of journal references. Second set of journal references. Third set of references. Thank you for watching this video. Please subscribe, like, share, and post your valuable comment below this video. Kindly press the bell icon after that for getting all updates.